Hi everyone, my name is Julia Cheng and my mentor is Natalie. I had the opportunity to work as an assistant in an oral surgery office for the past 3 years during my school breaks. There, I not only learned skills as a dental assistant, but also discovered many intriguing details about science, medicine, and how surgeries work. I came across an interesting question that the surgeons were also pondering. Were antibiotics effective in preventing infections after wisdom teeth surgery? Realizing how finding an answer for this question could improve care for many patients, I decided to conduct research on this topic. I'm presenting from Saratoga, California, and I will start the presentation now. So, the primary objective of this study was to assess the effectiveness of antibiotic prophylaxis in reducing postoperative infections following third molar extractions in a private practice setting. Secondary objectives including identifying additional predictors of infection such as patient age, smoking status, and follow-up type were also done. The findings aim to inform evidence-based practice-specific antibiotic stewardship strategies. Numerous studies have investigated the effectiveness of antibiotic prophylaxis in reducing postoperative infections. The results from these studies have yielded mixed findings. Meta-analyses have contributed to a general clinical consensus against routine use of antibiotics for third molar surgery, given potential risks such as allergic reactions, gastrointestinal side effects, and antimicrobial resistance. The American Dental Association guidelines recommend reserving prophylactic antibiotics for high-risk patients, such as those with diabetes, smokers, or individuals with compromised immune systems. Nonetheless, translating these recommendations into private practices can be complex. Differences in patient demographics, postoperative compliances, surgical settings, and surgeon experience may affect outcomes. However, most research to date has been conducted in academic or hospital environments, which may not reflect real-world private practice conditions. After understanding the topic of this study, we will now move on to how it was conducted. A total of 406 patients who underwent one or more third molar extractions between August 1st, 2024 and January 31st, 2025 were included. All procedures were performed by 3 board-certified oral and maxillofacial surgeons. Electronic health records were reviewed using the OMS Vision Practice Management software. For each patient, we extracted demographic, clinical, and surgical information. For statistical analysis, the following variables were included in univariate and multivariate models, such as age, sex, office location, surgeons, antibiotic prophylaxis, smoking status, diabetes, immunocompromised status, pre-existing infections, and postoperative follow-type. This study was conducted across 2 private oral and maxillofacial surgery practices located in Santa Cruz and San Jose, California. 3 board-certified surgeons with over 10 years of clinical experience performed all procedures. For anonymity, the 3 surgeons are referred to as Surgeon A, B, and C throughout the study. Surgeons A and B routinely prescribe prophylactic antibiotics for most patients, while Surgeon C used a selective approach, limiting antibiotics to patients with perceived high risk. This natural variation allowed for meaningful comparison within a consistent clinical environment. All statistical analyses were performed using R version 4.5.1 in RStudio. Univariate analysis assessed the association between each variable and the infection outcome using chi-square tests for categorical variables and student t-tests for continuous variables, such as age. A multivariate logistic regression model was used to adjust for potential confounders and to estimate adjusted odds ratio with 95% confidence intervals. A p-value of less than 0.05 was considered statistically significant. So what did we find using these tests? Of the 406 patients that underwent wisdom teeth extractions, 31 patients developed a postoperative infection, while 375 patients did not. Patients who received prophylactic antibiotics had an infection rate of 7.4%, while those who did not had an infection rate of 8.3%. There were minimal differences in infection rates across surgeons ranging from 7.2% to 8.2%. Regarding age, patients aged 0 to 25 had the highest infection rate, which was 9.9%, compared to the 1.4% in patients aged 26 to 50%. No infections were observed in patients over 50. Patients with an in-person postoperative visit had infection rates of 7.7%, similar to those who had remote follow-ups, which was 7.6%. Infection rates were slightly higher among females compared to males. Several variables, including smoking status, diabetes, immunocompromised status, and pre-existing infection, had very few exposed cases in the sample to allow meaningful statistical analysis. In this chart, only the age variable was significantly associated with postoperative infection because P was less than 0.001. All of the other variables, including sex, office location, surgeon, antibiotic use, smoking, diabetes, immunocompromised status, pre-existing infection, and postoperative follow type did not show statistically significant association because their p-value was greater than 0.05. This means that antibiotics are not associated with infection rate, and age is the only variable that is clearly associated with infection rates. This table presents the values of multivariate logistic regression analysis, adjusting for potential confounders. Antibiotics still did not relate to infection rate. Age, however, remained the only variable significantly associated with postoperative infection. This indicates for each additional year of age, the odds of postoperative infection decreased by approximately 10%. No other variable demonstrated a statistically significant adjusted association with infection risk. Now that we have analyzed the data from the study, we can apply these results to real life. This retrospective cohort study found no statistically significant benefit of prophylactic antibiotics in reducing postoperative infection after third molar extraction. The overall infection rate was 7.6%, with similar rates among patients who received antibiotics, which was 7.4%, and those who did not, 8.3%. Importantly, more than 80% of infections in our study occurred after postoperative day 15. Most prescribed antibiotic regimens are only effective for 5 to 2 days postoperatively. Therefore, it is plausible that the prophylaxis had little influence on infections developing outside the therapeutic window. This highlights a potential mismatch between antibiotic duration and the time of typical infections. Given that our study findings show no statistically significant reduction in infection rates associated with routine antibiotic use, surgeons A and B decided to no longer prescribe routine antibiotics in favor of a more selective risk-based approach. Age was the only variable significantly associated with infection risk in both univariate and multivariate analysis. Patients aged 25 and under had a postoperative infection rate of 9.9%, compared to the 1.4% for those aged 26 to 50 and 0% for patients older than 50. This inverse relationship may reflect greater surgical extent in younger patients, such as full bony extractions for all wisdom tooth molars, or lower compliance with postoperative care instructions. Interestingly, prior studies have reported both increased and decreased infection risk with increasing age. Our findings suggest that age-related risk in private practice settings may differ from university-based populations. Younger patient age emerged as a significant predictor of postoperative infection. As such, oral surgery practices may consider reinforcing postoperative instructions and providing closer follow-ups for younger individuals undergoing third molar extractions. Therefore, I created an oral hygiene instruction video that will be given to all postoperative wisdom teeth cases in the oral surgery practice that this study was conducted in. Here are my works cited, and thanks for listening.